lateral canthotomy and cantholysis. That is very important procedure in case of craniofacial injuries when the patient presents with periorbital or orbital hematoma and patient has got significantly reduced visual acuity, and when you shine light into the pupil there is no response to the pupil to light. So this is a clinical judgment. If you check orbital pressure at that moment, it will be more than 40. That will indicate that the patient has got orbital compression syndrome. So it's a time critical procedure. You need to release the orbital pressure as soon as possible after the decision. All you need is lignocaine with adrenaline, straight artery forceps or needle holder. If you want, you can use size 11 scalpel or scissors, and you need tissue holding forceps. So the steps will be after proper explanation and consent. You will clean using aqueous chlorhexidine the lateral canthus of the eye. That is medial canthus, that is lateral canthus. Take lignocaine from inside out. Inject about 1 to 1.5 ml of lignocaine with adrenaline. Give it about 5 minutes for the local anesthetic to properly work. After that, you can take straight artery forceps or your needle holder and apply it on the lateral canthus from inside out and leave it on for at least 1 minute. That will devascularize the tissues, and that will later on help by producing a bloodless field of vision for the surgeons. So at the beginning of procedure, you can see that the inferior eyelid is very tight and you cannot move it much. I will use scissors in this procedure. So make an incision in the lateral canthus about 1 centimeter. And invert the incised margins of the lateral canthus to visualize the inferior crest of orbital septum. Once you divide the inferior crest, you can check the mobility of inferior eyelid. If there is immediate release of pressure, patient will feel immediate relief of pain and improvement in vision. If you shine light into the pupils, you will start seeing the pupil response to light. And you can confirm it with digital tonometry. The pressure will be less than 40, around 20 millimeter of mercury, which is normal. If not, then you have got the option of going back in, and you can divide the superior crest of the orbital septum. And now we have totally released the lateral tendinous attachments of orbital septum by doing canthotomy and cantholysis. And now we can see that the inferior eyelid is much more mobile, and we can confirm it by the pupillary response to light and patient's response. The patient would have immediate improvement in vision and the pain will immediately settle. You can leave the incision open and it will heal by secondary intention. If you want, you can close it by 6-0 per day. And afterwards, we'll discard the sharps and thank the patient.